Welcome to the second part of our joint AO Spine BUS session focusing on spinal oncology. Please let me welcome my colleague and co-chairman, Jeremy Reynolds from Oxford. We are going to have two speakers. First talk will be focused on genomics, which we all agreed is the future of oncology and spinal oncology among it. We've got Professor Andrew Beggs, who's a professor in surgery and cancer genetics at the University of Birmingham. Our work colleague, who spent majority of his professional career looking into genomics of GI tumors, having run a few clinical trials and participating in Genomic Tumor Advisory Board. I think his talk will be very exciting. He's unfortunately not able to join us for the discussion, most likely due to an unexpected personal circumstances. But both Jeremy and myself feel very happy and ready to have this discussion regarding applications of genomics into spinal oncology afterwards. So I think we are ready to start.
Hello and welcome to my talk on genomics and its role in surgery. My name is Professor Andrew Beggs and I'm a Cancer Research UK Advanced Clinician Scientist at the University of Birmingham. I'm also a consultant colorectal surgeon. Now, what I want to talk about first is how that you use stratified medicine every day. It's something as simple as using an insulin sliding scale for patients with high blood glucose as a form of stratified medicine. So actually, as clinicians, we've been using stratified medicine for a long time. You measure patient's blood glucose via fingerprint and you then prescribe an insulin sliding scale. And so the concept of using a biomarker and taking it into a clinical practice is not new to us as clinicians. Now, what's changed recently and over the last 10 years is that we're on the cusp of a genomics revolution. So you've all probably heard of the Human Genome Project, which sequenced the first whole human genome. And this was in a sort of mixture of people, but the majority of it was from a man from New Jersey. And as you can see here on the slide at the top left, it was an expensive project, £3 billion for one genome. It took 15 years. And the machines they used required essentially what was football pitched. And things moved on quite quickly. 5 years ago, we could do benchtop whole genome sequencing for about £1,000 a genome in a day. And, you know, it wasn't a particularly big machine, as you can see in the middle. And now on the right, we've got nanopore sequencing, which is coming down in cost all the time. And you can do in a day or even less at a very small amount of money. And what we've seen in genomics is very much what we've seen in computers and microprocessors. So you may have heard of Moore's Law. And Moore's Law refers to one of the founders of Intel, who said that every year the amount of transistors and the cost of processing doubles. And it's been the same it's been the same more recently with genomic sequencing. So as you can see in this graph here, the cost of the human genome starting at $100 million in 2001 has dropped rapidly only in the last 10 to 15 years. In about 2007, when Illumina sequencing became more widespread, the cost of whole genome sequencing began to drop very, very rapidly. And although this graph only goes up to 2012, we're now down below the 1K mark, and we can sequence a whole human genome now for about £200–300 if it's just in the germline. Now, how can we use genomics to stratify these patients? Well, we can use molecular genetics with mutations, so DNA-seq. We can use changes in gene expression, such as RNA-seq, or we can do epigenetic modifiers, so how methylation, which can switch genes on and off, ChIP-seq and others. But there are other technologies we can use, which we aren't going to discuss today, but things like molecular imaging, PET scanning. We can look at proteomics and metabolomics. And a good example of how stratification work is this. And I'm going to use, I'm afraid, and I know it's difficult with spinal surgeons because I'm not doing a tumor that's relative to you. You do see colorectal spinal metastases. We're going to look at how even the basic understanding of genomics can give an important understanding into patients' progress. So most colorectal cancers have a dysregulation of something called the epidermal growth factor receptor pathway. And this is, as you can see in the diagram, a pathway that signals cell proliferation and migration. And it was because it was thought to be virtually ubiquitous, the dysregulation of this pathway. In the early 2000s, the monoclonal antibodies were developed to target this, cetuximab and panitumumab, to give to people who had overexpression of this pathway. And it was thought this would be the answer to colorectal cancer, that this would cure the majority of it because it was blocking the growth signals. So they carried out a randomized controlled trial, as you always do, and showed that using EGFR monoclonal antibodies was a failure. There was no difference in panitumumab, as shown by the blue arm, and orange in the best supportive care line. And this was very disappointing, obviously, because it wasn't what we understood about the biology of these tumors. But part of the problem was that we didn't understand how genomics could affect these tumors. What seemed to be an obviously overexpressed pathway wasn't in these patients. And they found that with mutations in the MAP kinase signaling pathway caused you to be unable to switch off this pathway. So whether you blocked it or not, as you can see, cetuximab and panitumumab work at the top here. If you had mutations in RAS or BRAF or PI3 kinase, you could end up struggling to get these things going. So they found generally that mutations in KRAS, NRAS, and BRAF were enough to prevent panitumumab, cetuximab from working. So when they stratified the patients by this, they found that there was a clear difference in survival. So we now know that, for instance, even by doing a very simple genomic medicine assay, KRAS mutation, if you select people who are not having a KRAS mutation, people with panitumumab therapy will have a good benefit, as you can see here in this survival plot. So the take-home message is that if you're going to design a biomarker or use a genomic medicine assay for this, you have to understand the underlying biology of what's being examined. Now, it's not always as simple as KRAS and BRAF. There are different types of biomarkers. So biomarkers could be complex, i.e. multi-gene. So it might not still be KRAS. It could be any gene, any combination of genes, or it could be a more complex one like RNA gene expression. But biomarkers can divide into two things: predictive, i.e. you predict a response to a therapy, you can select people, and if the therapy does include surgery, or prognostic, you can predict how patients will survive or disease will progress. And I'm going to give you an example of that one now, once again in an epithelial tumor. So the DDRD stratification assays in breast cancer, and this is being used more and more. And although the technology in it was quite old, what they wanted to basically understand is that the standard of care chemotherapy they gave to patients in a neoadjuvant setting, platinum-based chemotherapies, if it would work or not. And one of the things we know about platinum-based chemotherapy is that it matches with in vitro markers of double-strand break repair. And we know that people who deficient double-strand break repair have a different response to DNA damaging chemotherapy from those that don't. So they developed an RNA expression assay to predict who would have a good response based on their changes in DNA damage. So as you can see here in the assay, if they're DDRD positive, in other words, they've got deficiency of DNA damage repair, and you give them DNA damaging chemotherapy, they have a much better survival benefit than those who don't. And this obviously was a quite interesting finding. I mean, one of the things to do with this chemotherapy is that it is quite toxic. It causes problems with neuropathy and many unpleasant side effects. So from this point of view, it's a successful assay and is being rolled out into clinical practice. As you can see here, when you didn't give oxaliplatin to either group on the right, there was no survival benefit seen. So you can understand how these people will end up having benefit from this kind of treatment. So it's a predictive type of assay. It'll predict the patient's tumors will respond or not to a particular kind of chemotherapy. If they respond, they'll have increased survival. And if the patient's not likely to be responsive, then we don't give the chemotherapy, and so they can get to surgery quicker. So a lot of the way what genomic medicine is going towards is based around this ability to stratify patients, and the stratification can be quite exciting. So one of the big terms and topics, and I'm going to cover it now, is immunotherapy. So immunotherapy needs to use genomics, and we'll talk about that to understand how to identify. But there are multiple different ways to use immunotherapy. So the first one here is a baby girl who had an aggressive leukemia and had CAR T cells harvested and used to essentially completely wipe out her leukemia. And and this girl is still alive now. They were genetically engineered to target a surface protein on this leukemia and wiped it out in her body. And as it adapts, you can change the surface protein. There's also other examples, so other things, specific immunotherapy, so on PD-1 blockade, has been used in people like former President Carter. Now, he had metastatic melanoma. The melanoma spread to his brain, and he was given pembrolizumab, which is a PD-1 blocker. And this completely wiped out his metastases, and he lived for several years. He's still going several years after having had this immune therapy. So he's gone from having what seemed to be an irresectable disease to one that's been cured by stratifying the patients appropriately. So how do we understand where tumor-specific immunity comes from? Well, tumor-specific immunity comes from mutations, essentially. And the more mutations you have, especially non-synonymous mutations and frame-shift mutations, the ones that cause a change in protein structure or function, you produce something called neoepitopes. So these are proteins that are foreign to the body and are seen by the immune system, expressed by MHC and linked to tumor visibility. So the assay we use for this is tumor mutational burden. And I'll talk a little bit about how we measure tumor mutational burden in a minute. Now, we've used immunotherapy in other diseases like colorectal cancer, but this applies to a lot of malignancies where advanced stage disease, especially with spinal metastases, the survival is only about 10%. And so we've talked about CAR T cells, and I'll explain that in a little bit, that you put back into patients. We've talked about cancer vaccines, and you need genomics in order to use cancer vaccines. And we've also talked about checkpoint blockade, so immunotherapy. Now, just to give you an example of how CAR T cells work, what you do is you need to understand what your target is. So you sequence the tumors within the patient, you find either a mutation or an epitope on the surface that is expressed and you can target, and then you design a T cell against it. But you have to use the patient's own T cells. So you gather the T cells, you put the protein that you want to target with CAR T cells into a vector that transfers it into the T cells, and then you grow them up, and then you transfer the T cells back into the patient, and it targets specifically the finding or the mutation that you want to understand. And then you can measure this with genomics. It says RT-PCR and flow cytometry, but you can also use this to target. You can use digital PCR, you can use next generation sequencing to measure what's called minimal residual disease. And this has a profound implication across multiple types of malignancies going forwards. Now, another example, just to show you how powerful immunotherapy can be. This is a CT scan of an abdomen. You can see here on the top right, there is a large tumor there. And the two tumor immunity targets are called pembrolizumab and nivolumab, and these target a receptor called PD-1. And what PD-1 does is it prevents T cells from being switched on. And so if you can identify a tumor that might be susceptible, then by giving a PD-1 inhibitor, the immune system gets unleashed against the tumor. And as you can see here, there's the tumor there. And in this CT scan here, you'll have to take my word for it. It's shrunken away and almost disappeared completely after 6 months of treatment. And certainly I have had several patients who have had profound responses to immunotherapy in a variety of malignancies that I've not been unable to operate on. And by giving immunotherapy, I have allowed these patients to get to the stage where they can have surgery. And so this is an enormously powerful tool for surgeons, because they can end up having a patient who's essentially inoperable and turn them into an operable patient, which is quite attractive. But you need to be able to classify this immunogenicity. You need to understand how it happens. And so I'm going to come on to the sort of main focus of this talk, which is genomics. And how do we use genomics to do this? Well, there are a number of biomarkers that exist across tumors, and the main one that you need to know about for patients having immunotherapy is microsatellite instability and tumor mutational burden. It says lung, probably others. We now know for both of these that people who have immunotherapy have a widespread response to PD-1 therapy. And the way you measure this is by, instead of having to do whole genome sequencing, so the entire cancer genome, you can do targeted sequencing using a smaller panel, which is big enough to be able to call tumor mutational burden, but small enough and cheap enough in order to be run on everybody. But another thing to talk about, this is an example of a panel that's going to be used across the NHS, hopefully the TrueSight 500. There are other oncology markers that we can do. And, EGFR is important for some types of metastases, fusions between genes like ALK and ROS, NTRK, for which now there's funding. NTRK is a very rare fusion, about less than 1%, where two genes stick together, but there's a drug that could be given, larotrectinib, that will basically melt the tumor away. And we've had patients whose resectability has been aided by allowing the test for NTRK fusions and then operating. There are other biomarkers that will come forward, and this panel is designed to cover them. So how does it work? How do you go from a patient sample in order to a variant that's called here that you can use to improve your own practice? Well, the workflow, and my laboratory took part in this, was the TrueSight 500 workflow. We take a formalin-fixed paraffin-embedded specimen, so the block here that you've all seen. And the difference between this and others is that now we can actually get usable nucleic acid out of paraffin blocks. It's always thought that only fresh tissue was useful for nucleic acids, but we know we can extract reasonably quality genomic DNA or RNA from a block and use it for analysis. So there are a variety of kits we use to do it. And then we do the what's called the library preparation. We make the sequencing library, which takes 2 days, and then we sequence it. And then the data that comes off the sequencer then comes back into a commercial pipeline that calls the mutations. And as we do in the genome tumor boards locally here, allows us to identify treatments for the patients. And we can stratify people into both adjuvant and neoadjuvant therapy. In other words, improving their outcomes and prognosis. And this has got a wide variety. We do this with sarcoma already. We do this with most solid tumors and blood cancers now. So going forwards, this is going to roll out and be a standard of care across the entire NHS, which is enormously exciting. It also shows that the NHS is truly leading the way in this type of work. We have done this as well. We obtained 200 samples via FFPE biopsy, and we compared them back to fresh frozen WGS samples. We publish this now, it's not preliminary anymore. We found there was very good concordance at TMB, but also a mutational cause between the fresh frozen whole genome sequencing you do, that's difficult to get, and FFP. And the reason this is important, as although most spinal oncology centres, for instance, are within teaching hospitals, the process of getting tissue fresh from a specimen and sent off to a laboratory to be sequenced can be quite laborious, whereas the process of getting tissue from a formalin block is much more reasonable and straightforward, and most hospitals will be able to do it. So this allows these kind of things to be accessed by any patient really within any centre anywhere, as long as standard protocols are finished and followed. Now, you've all heard about the 100,000 Genes project, and you may have wondered, was there any point to it? Did we find anything? And I'm going to show you something from, my interest is in retroperitoneal sarcoma, as well as tumours. So I'm going to show you an example of how you can use the 100,000 genome sequencing data to associate with rare cancers. So we were a centre for a pre-pilot for 100,000 genomes project. We took we have a big sarcoma unit attached to us, and we took a small cohort, of patients with a rare tumour to see if we could use whole genome sequencing, in this case, RNA-seq and methylation array studies, in order to understand what made them tick. So could we find new treatments? Could we do new therapies? So the example of this is retroperitoneal liposarcoma. It's a rare tumour. As you can see here, there's a Spencer Wells next to it, and the size of the tumour is quite large. Generally, when they're taken out, as you can see on the CT scan here, from the surgical point of view, the tumours can be up to 20 kilos in size, or weight, I should say, and they can, in the end, because in order to ensure margin clearance, you have to perform quite extensive surgery. You have to remove adjacent organs that it's in contact with. The other thing we know is these tumours are very unresponsive to chemoradiotherapy. There have been trials looking at this, the Strauss trial for one, and it's not really shown any benefit to chemoradiotherapy. But these tumours have not really undergone comprehensive molecular profiling before. We understand some of the biology of them, the MDM2 amplification, but we don't understand any more details. So we carried out rare tumour panomic profiling. So we, in collaboration with Illumina, carried out tumour normal whole genome sequencing on fresh frozen material. We then did RNA-seq, and we also did methylation to try and understand what makes these tumours tick. It's a very limited study, but it's just more to illustrate the power of this type of approach. Now, we know that MDM2 amplification is basically ubiquitous in liposarcoma, and this is what's being used. This is what gets used to identify it. But we now know that the amplification spans most of chromosome 12. As you can see here, this is a chromosomal eye diagram. This is the long arm of chromosome 12, and MDM2 is located about here. And as you can see on this graph below, the whole region is amplified around here. So it's multiple genes, multiple targets within, and we show that with the whole genome sequencing. But there's more to these types of tumours than just the MDM2 amplification, which is probably part of it, but not all of it. So one of the things we carried out whole genome sequencing, and you may not be familiar with this, is what's called an IGV plot, which allows us to understand if there's any recurrent mutations. So each one of these bars here is a tumour. And the red and green line here, you can see there's a tumour in different mixtures of mutant alleles. And this demonstrates, down here, these are normal samples, and this demonstrates that we can actually detect what seems to be a recurrent mutation in these tumours. There's an example there for you. And in order to validate this, we carried out Sanger sequencing, and we confirmed that this was a stop gain in a gene. And what the gene does is called a fork-head box gene. So this is a gene, a transcription factor that affects the development of these tumors. And this had never been seen in these types of tumors before. And we're currently carrying out some functional work in order to understand how these patients will be affected by this mutation and what we can do. There's the mutation there, as you can see. You can see 2 lines there on the Sanger sequence. It proves that the mutation is genuine and not just a sequencing artifact as was thought previously. Now, one of the other interesting things that came out of this work is that we demonstrated that liposarcomas are polyclonal. So what does that mean? Well, essentially, one of the reasons we think that tumors are so resistant to treatment with chemoradiotherapy is that they evolve into multiple clones. Tumors are very Darwinian. Essentially, if you put any selection pressure on them all, they will evolve resistance to treatment. One of the things we showed is that these tumors are inherently polyclonal. So in other words, they seem to have multiple different clones with different resistant patterns. And this may explain why it's resistant to chemoradiotherapy. Now, you've seen all of this, and you may think, so what? And you may be right, because at the moment, there's no targets for TP50. There's no targets for the gene that we saw, the fork-head box gene. So understanding other targets, knowing that other mutations that can happen in genomics are quite important. And so we carried out RNA sequencing, and unsurprisingly, we saw that they turned from a lump of fat into a tumor, which wouldn't be a surprise to anybody. We saw massively dysregulated glucose transport, which once again is not a surprise to anybody, and also TP63 signaling dysregulation, which is once again not a surprise. When we looked at methylation, now methylation is important because it's where a methyl group is added onto a tumor, and it can inactivate a tumor and allow it to, inactivate a gene within a tumor and change its products. We call it an epimutation. So instead of an actual sequence change, the methylation switches the genes on and off. So we found, for instance, that EGFR was hypomethylated. So that would suggest that the EGFR pathway is always switched on. So we talked earlier in the talk about how it may cause hyperactivation. And this may be that cetuximab is a potential treatment for this. We also detected abnormal methylation of the PI3 kinase pathway, and this has led to further dysregulation of MAP kinase signaling. And so there are drugs that exist out there that we can use to target MAP kinase signaling. So once again, this may be a target for these type of tumors. This is early work, but it means we can have a stratified medicine trial, and we're actually putting together now a sarcoma study where we understand the mutations that we see in sarcomas and also target them with novel therapies before surgery in order to shrink them down, in order to make them more likely to take out. So given what I've told you, we are going to make the quite strong statement that genomic medicine will cure most cancers in 20 years. And I'll give you some examples of how that will happen. Now, I'm going to talk about a lung cancer study from one of my collaborators, Gary Middleton, and he carried out something called the National Lung Matrix Trial. Now, a lot of clinical trials in any type of cancer have been very much, well, we're going to look for this biomarker and we'll give you a drug based on it. But what's different about the National Lung Matrix Trial that's now open and still ongoing on, is getting towards the end now, is that we assigned treatment according to molecular phenotype. So it was in lung cancer, you take a biopsy of the lung cancer, and from that, you target the patient's treatment depending on what mutation you find. But it's not just a question of giving a simple mutation. It may be a complex set of biomarkers that you give a particular drug for, or it may be one where you give a patient one therapy, they develop resistance to it, and you rebiopsy and then treat them again. And another advantage of this trial is it's quite small. They're small arms. So each one of these molecular alterations you'll see will be quite small. You probably only recruit 30 patients a year. And so there's a novel type of trial methodology called Bayesian trial methodology, where we can use a small amount of patients in order to make a go, no-go signal in patients with this type of tumor. And the National Lung Matrix Trial has actually been published in Nature now, and it did show molecular benefit to some arms in patients who are treated in this way. And certainly a lot of the ways we move now will be towards giving people neoadjuvant therapy with these drugs in order to shrink their tumors down and make them more likely to work. Another example is the Determine study, and this is one that I'm involved with across Manchester, the Marsden and others, and the Christie. And it is to give patients with rare cancers new treatment options. So the way it's going to work is that patients with rare tumors, and it's pan-rare tumors and not one particular tumor, will have local genomic profiling validated assays. So what that means, for instance, is things that are approved at the moment will be panel sequencing, MTRAC fusions, ALK-ROS fusions, things that might be approved for that tumor of interest or as a last case scenario, and it'll be discussed in the local molecular tumor board. But at that stage, he'll be enrolled in determined. So all patients with all very rare tumours in the centres will be recruited to determine. What we're doing differently, and it's an evolution from Matrix, is we're taking a mandatory frozen tissue biopsy, both pre-treatment and ideally post-treatment. And the idea is to work out why these drugs don't work in certain tumour types and why they do work. And to do that, we're going to use whole genome sequencing and RNA sequencing to target them both pre and post-treatment to understand what changes that the drug drives and how resistance emerges from these people. And it can follow back. So for instance, if we do find another drug, they find a benefit from this sequencing, they can then go back in the trial and receive that drug. The other option that comes into this for patients who will do it, and it sounds quite morbid, but it will be quite useful in this case, is something called the P study. And the P study is a post-mortem biopsy study of people with metastatic disease. So there are people who will consent to having an ultra-rapid autopsy after death and sampling their metastases. And this allows us to understand why the treatment didn't work in them and hopefully improve the care of other people. And so this is really quite fantastically interesting and useful for patients in genomic medicine, because we hopefully will be able to understand better what makes these drugs not work and treat patients differently. So my prediction is that cancer will become a chronic disease. You will diagnose a patient with cancer, and instead of doing a biopsy like you've seen the other options, doing a liquid biopsies, you can take blood and look at the circulating tumor DNA, and you can identify these mutational drivers of cancer and carry out surgery and or targeted therapy, because surgery is still an important way of treating cancer. The patient's either cured or there's a recurrence and we go back in the pathway. So let's give you an example of circulating tumor DNA. So in case you didn't know what it was, this is where you get a stone of blood sample, put it in something like a lithium heparin tube, spin it down, and you have the erythrocyte fraction, the red blood cells, the buffy coat, which is leukocytes and platelets, where most of the genomic DNA is, and the plasma. And within the plasma, there's free circulating DNA that is proportional to the size and stage of the tumor. So instead of actually having to take a sample from the tumor, because the tumor shreds DNA into the bloodstream, we can detect this as part of a liquid biopsy. And it's quite important because from that you can monitor and follow disease progression. You can understand how these things work. And so from this, you can see how patients' tumors evolve on treatment. Now, it's not perfect in that if you've got a small tumor, you may not shed a lot of DNA into the circulation. And the other issue, depending on how you take the blood, if there's genomic DNA contamination, it may be difficult to tell a mutation in a tumor apart from normal mutation. Because one of the things that's not realized until recently is that we all carry normal mutations in our white cells that are just a consequence of aging, called clonal hematopoiesis. And this means that we still have a little bit of work to do to understand how we can use liquid biopsies in the clinic. But there are companies like Grail, who are a company working with NHS England, who want to use this for early detection. And there are people like us who want us to use it for early recurrence detection. So in replacing some of the surveillance techniques we might use, like irradiating patients with CT or MRI, or doing an MRI scan, or recurrence blood tests. It will also be useful in order to understand how patients could be stratified in some of the treatments you've seen. And we would have a ctDNA arm and determine, the idea being to try and prevent patients from having to have a biopsy in the first place if we can get enough information out of the ctDNA. So genomic medicine is what we call personalized medicine, and I think the vision in the UK is to try and make it standard of care for all patients. And like we have done with blood tests, it will become as ubiquitous as part of the record as a routine blood test, and this is already starting to happen in many centres. And just to give you an example of how other dramatic responses you've seen here, this is an example of a patient with metastatic melanoma, and as you can see, being spinal surgeons, there's multiple metastases in the spine there from the melanoma. And this patient, melanoma, one of the things we know about it is that it's driven by a gene called BRAF. And on the right here is a PET scan after they've had BRAF kinase therapy and then immunotherapy. And as you can see here, there's been a complete regression in the tumor. So by using genomic medicine and by understanding the biology of it, we can affect profound patient choices and change their pathology and also their prognosis. Going forwards, we may even be able to edit the genome in the tumor, as things that you've seen like CRISPR and Cas9 technology will allow us to profoundly affect signaling pathways within the tumor. And you've seen with the recent vaccines that have come out, using genetically edited constructs to affect changes in patients is certainly possible. And mRNA vaccines like the Pfizer vaccine you saw was originally designed to treat cancer by targeting neoadjuvants. So we can only do this with an understanding of genomic medicine. So in conclusion, molecular stratification is rapidly moving from a lab tool to a clinical test, and we'll need to understand genomic medicine, especially molecular genetics clinicians. We all understand blood tests now, X-rays and CTs, but we will need to get to the stage where we can understand molecular genetics. But because I'm speaking to an audience of surgeons, despite all these advances, surgery still cures 70% of all solid cancers. That's the primary therapy of choice. So what we're seeing is that surgery will be one of many treatment modalities that we will undertake in order to improve patients' quality of life and care overall. And thank you very much.
So Martin, I know that we're relatively tight for time. I think that's outstanding sort of where we are at the moment in oncology, and I don't know if we want to make any sort of big questions now from the audience, or whether we're just going to make a few comments. I would just comment to say that nobody is expecting a spinal surgeon to have a comprehensive understanding of what's just been discussed, because it's really complex, and life is too complicated to start squeezing those sort of details in. But I think what's really, really important is that many of us who went to medical school best part of 20 plus years ago, our understanding of cancer is different to what cancer is now. And so an often nihilistic approach to patients with maybe what seems like very extensive cancer is maybe not appropriate if the patients have not had access to immune therapies. And so if you've got a disease which seems progressive but is essentially, for want of a better phrase, virgin to treatment, then being nihilistic about the spinal oncology issue, metastatic spinal cord compression, for example, may actually mean that you're preventing that patient from going down a treatment path, because most of those immunotherapies are dependent on you having a high performance status. And if we do not prevent cord compression or treat cord compression in the acute phase because a patient seems to have a lot of disease, then actually you're excluding them from the potential life-prolonging treatment. And that was not the case when we were looking at things like the Patchell study and all that kind of stuff.
Jeremy, can I apologize, please?
Yeah.
The next talk is 30 minutes and 15:30. Boriani is going to come in, please. Yeah. We're already 4 minutes over. Sorry.
Okay, let's move forward.
Hello, I'm Catherine Coyle, and thank you so much to the organisers for inviting me to speak today on proton beam radiotherapy for spinal sarcomas and to BritSpine 2021. So in 18 months we've been open, we've treated just fewer than or just less than 100 patients, a third of whom were primary spinal sarcomas of each of these sites. Nearly all of the patients were treated post-operatively, but some have had radical definitive treatment, and a few have had a mixture of pre-op, which is 19.8 Gray RBE in 11 fractions, and then the rest of the treatment post-operatively, and that's the area that we really want to expand. So as you know, the proton advantage is that there's more dose given literally to the tumour plus whatever margin you decide around it, and far less dose to the normal tissues, both in front of and more importantly, beyond the tumour. So the good thing about protons is that they stop on the patient. The not so good thing is we don't always know exactly where they stop. And this range uncertainty has several reasons, but the main sources are the three below. The first one is related to physics only, so we won't talk about it anymore, but a little bit of the discussion will be about inhomogeneities and patient anatomy changes. But essentially, I guess the message is protons is very much more difficult in terms of its complexity than photons, and there is no give whatsoever. So the red is a photon going through the body and the blue is a proton. And if we add a little bit of inhomogeneity, such as air, like lung, what happens? Well, with the photon, not that much happens. There's a bit of a change, and it goes through a little bit more rapidly. There's a little bit of a higher dose beyond. But what happens if it's a proton? Well, quite a lot, because instead of that little change of a few percent, you actually could have a change where you have a full geographic miss. If we demonstrate in this one where you're trying to spare the rectum and you've got a nice curve around a rectum which is full and without any rectal gas, well, what happens if one day the patient has some rectal gas and essentially you're treating the whole of the rectum way beyond the doses that you were intending to prescribe? So for the patients who have spinal sarcomas, the lower thoracic spine, lumbar and sacral spine patients, we immobilize them as comfortably as possible in the prone position. And that also allows for the kidneys and the bowel to move forward a little bit. And as the first step of us trying to ensure that we have a maximum accuracy. Cervical spine, upper thoracic tumours, we would prefer them supine position with a mask and a headboard. And also for the thoracic, lower thoracic and upper lumbar spine tumours, some of them, not so much the spinal ones, but even so we have to think about it. We might need a 4D CT to take into account respiratory movement and diaphragmatic movement, etc. The other thing that we have to consider is in the postoperative patients is what metalwork is in there. So obviously stainless steel or titanium, not only is there an underdosage, but there is an overdosage, and therefore that's really critical when we're talking about tumours that are really close to the spinal cord, and the stabilization hardware is often close as well. So that's why we prefer, where possible, proton count materials with carbon, mostly because we remove the overdosage risk and we minimize the underdosage risk. So that if we have a treatment planning system, we can actually use the CT image and recognize that the treatment planning system and the CT image are aligned, and with the dose that we think we're getting, we are getting. So this is a patient who had cobalt chromium for a bit of a strange tumor. It was an osteosarcoma of the lumbar spine with a huge extraosseous component posteriorly. We were very concerned about the coldness of some areas and concern also about the spine. We therefore didn't dose escalate as much as we might have, and we used multiple beams to compensate. But of course, we can't use beams that go through the bowel because of the variability of gas. In terms of that use of extra beams, that is somewhat easier in the cervical spine. And on the left-hand side, we had a patient where we were quite concerned about the titanium. We were also concerned about where we felt we were safely able to give the dose to the spinal cord. And we were able to minimize, not take away our concerns, but minimize our concerns by using a different beam arrangement, which is shown on the right side two images on the screen. We also had a different patient who was referred with chondrosarcoma. They actually had some residual disease, and we felt that we couldn't offer them a safe treatment that was any better than photons. So we weren't going to be able to dose escalate, and we were concerned about the dose to the cord. So that patient actually got referred elsewhere, where they had their residual tumor removed and had carbon inserted. And we know that that's more difficult in the cervical spine. And the question we asked our physicists still was, are we doing this patient benefit by having multiple proton beam entry points? Or is that not the same as or similar to IMRT? And so they did a proton plan and a photon plan for us in this particular patient. It showed that, yes, there was a small benefit in terms of dose escalation, not great, less than 3 gray, but we're in the steep part of the curve, so that is still some dose escalation. And also, I think you can see that the patient got a lot more low dose, so a lot more acute toxicity and some late toxicity from a photon plan. This was a patient with the sacral sarcoma who came through, and on the left is their initial MR planning scan. We thought that everything was fine. We went through all of our treatment checks. Everything was great. He started treatment a few days in, everything was fine. Now we do cone beam CT on every single treatment, which is not something that some of the older centers can offer. And about 5 or 6 treatments in, we realized that there was a change in anatomy. There's a change in patient shape. And essentially, not unreasonably, given that he'd been lying prone with his buttocks in the air, covered by a thin sheet with a crowd of strangers, he had clenched. And when he was a bit more relaxed through treatment, he declenched. And the difference was about 5 millimeters, but that difference actually translated to about a 10% dose drop. So he had to go right through the process again and have a MR scan and replanning for the rest of us. So I'm going to give you some clinical examples here. There are 5 in total. And the first one was what we thought we might get, in that this was a sacral chordoma, small enough for the patient to be offered an operation, but the patient didn't want the functional result. So gross tumor volume marked on here in the orange. And then in the phase 1, which is the 50.4 gray RBE, in 28 fractions, 2 to 3 centimeters laterally, a centimeter anteriorly, and posteriorly, because there was no surgery, and the border was right up with the muscles and didn't go into subcutaneous tissue. And then phase 2 is the gross tumor volume, which is again in the orange with no margin. And the sagittal, the phase 1, includes the vertebra above and a vertebra below. And then the phase 2, as I said, is just the orange, and that brings it right up to 75.6 gray. The other colors are the extra margins that physics put on for planning. And we get a nice dose distribution. We're not giving too much toxicity to the skin. We've got nice clear dose in the high dose volume and very little dose overspill into the bowel where we don't really want to give it. So a perfect example of where protons work really well. However, the reality is not quite the same. 61-year-old lady who weighs 45 kilos, starts drinking at 4:30 in the afternoon, has this large tumor, which is also right from the beginning causing neurological compromise. Same approach, 50.4, then 25.2 to a total dose of 75.6 gray in RBE. So again, the tumor, rather larger tumor, is outlined in the red, and in the green, we have the margins laterally. We put a tiny margin on posteriorly, but because there's no subcutaneous tissue, that the nasal cleft is pretty much up to skin surface. And then there's the craniocaudal extent of about 2 centimeters or 1 vertebra. However, on this occasion, we have virtually no margin anteriorly. The usual checks have taken place with physicists to make sure that it's a robust plan. But during the tumor treatment, it is noted on the cone beam CTs that there are 2 problems. One, the tumor itself has got a little bit larger, which we think probably is edema more than anything else. But also posteriorly, she's got quite a lot more subcutaneous edema, and there's a change in the patient shape. So although that is only just a few millimeters, when you have no margin anteriorly, it meant that the anterior border of the tumor, instead of getting 97%, was actually only getting 85%. So again, back to the drawing board, and we had to replan her during her treatment. In terms of definitive PBT for sacral chordoma, And the Boston data was only 24 patients, and it took them 11 years to do it. As of this morning, with my 31-year-old, we are on our 11th patient in 2 years. And the Boston data also did a sub-analysis in patients who had more than 500 cc's. Well, that in the end is a gross tumor volume of 8 by 8 by 8. So Shri, one of our Proton fellows in the BSG poster this year, showed our surgical referral patterns and also questioned what our gross tumors size was, and in the mobile spine, how much different that was compared to the sacral chordomas, and trying to compare that in a way with the Boston data with all comers, and their median for mobile spine and sacral was 6.5 centimeters. So the question arises then, how safe is dose escalation above our initial starting point of 75.6 Gray? So we'd intended to go up to 77 and even 79, but all of our organ at risk data is coming from the Boston data, and the patient characteristics are very different. So far, so good in terms of our audit, which Maeve, another Proton fellow, also presented. And essentially, our audit is in all of the patients, not just the spinal sarcomas, and so far is very acceptable. The lymphopenia is an interesting one, and the lady that I presented, the 61-year-old drinker, her lymphopenia went on for about 9 months. What we haven't got, because we've only been doing this for 2 years, is late rectal toxicity on the rectum, bone and nerve, and that's what's making us a little anxious yet about trying to dose escalate. And so one of the questions is there another way of doing it, such as hypoxia manipulation? The question we get asked often, and we asked ourselves a lot, is what do you do when actually the tumor has been removed? And so a patient like this with a partial sacrectomy who post-operatively does have quite a few neurological problems and is planned for adjuvant radiotherapy, but this has not been discussed with us beforehand. So this was somebody that had their surgery, and then we were asked to give 70.2 Gray RBE equivalent. So pre and post MR scan, so it was a sizable tumor. And when we reconstruct on the CT scan where the tumor was, that is in the orange. And now, of course, tumor's gone. All that's replaced with that is radiosensitive bowel. So what we have to try to do is to make something up that is reasonable. And we still need to do this reconstruction of where the GTV is. And we still need to put on 2 to 3 centimeters of margin, which is now the magenta. It goes back beyond the muscles, and it is carves out along the bowel. And then after 50.4, our phase 2 can no longer be GTV with no margin. What we try to do is a GTV, looking at it and working out where the margins might be at most at risk and putting 5 to 10 millimeters on. So it's a bit of an odd looking plan. This was a patient who had an enormous tumor, and that's his pre-operative MR overlaid with the outline in green of the body contour for our planning CT. Patient has had a big sacrectomy, he's had a colostomy, he's got a catheter in, and obviously the two don't really marry up, so it's quite difficult for us to fuse. We have to try and do our best, however, and we come up with something that is this sort of beige color, and then we put our 2 to 3 centimeter margins on for the phase 1. This is really to try to show you the phase 2, which is the blue, which again is the reconstructed GTV plus a 5 millimeter margin, taking it right back off the bowel, and this side, because the margins, the soft tissue, were not quite so clear, then a wider margin there. And again, the yellow is added by physics for a physics planning margin. So the next patient is a 20-year-old. He's an outdoor pursuits fanatic. He has a minor chest injury and is found to have an abnormality on A&E chest X-ray. He is then scanned, and this thoracic tumor is operated on outside of a sarcoma unit without any biopsy. When they're in there, they find actually that this isn't quite going according to plan. There's residual disease, we think, left behind, as in we don't think it's recurrent. And the histology is a grade 2 chondrosarcoma, and he is referred to a sarcoma unit, but because of his outdoors pursuits and his desire to be in the RAF, he refuses further surgery. So this is to show on the top left is in red is his preoperative scan, and the red then marks out that gross tumor volume. That is then put onto our planning CT scan as a reconstruction. And then we try to work out on the red what margin we need to put around, bearing in mind this is essentially a whoops operation, and therefore we want to come right out to this area in the subcutaneous tissue, right out to the scar, because we're not entirely sure what's going on there. This orange represents the disease that we know is residual. We're putting a small margin around into the lung to allow for movement and respiration. And we take it off the bronchus, and because we aren't entirely sure whether the dura has been opened or not, we end up covering the dura in phase 1, which is what we would normally do in a post-operative case. The next slide is really just to show you that it does go right up to the spinal cord and how we've had to take that into account. So we think about this really hard because a phase 2 up to 70.2 Gray just doesn't seem enough for this person with residual disease. And we know that we're really restricted by the organs at risk, particularly the spinal cord. We take some advice from another proton center. They agree with us, but we really are no further on. And so we sit down together and plan things through, and we decide that the first phase, we're going to go for 45 Gray. And we're also going to be really careful that we don't give all of the dose to the spinal cord in that first phase. So we certainly don't want anything over 100%, but actually we're deliberately going to ask for it to be just slightly lower, so that we are covering the area of surgical risk. This is the dose wash for that. And then this is the beam arrangement, 2 beams. Then we get up to our 70.2, our normal post-operative dose. And in this, we call it a CTV intermediate. And essentially, that's the residual disease plus about 1 centimeter where we can, a little bit more over to the side along the pleura, but taking it off the spinal cord completely. And then we look at the dose wash and think, yes, that's not bad, but we need to do a little bit better if we can. And he has 4 beams in this arrangement to sort of try to smear out the dose to the skin. And we then get 7.2 Gray extra, right up to 77.4, and that is residual with no margin whatsoever. So that's very tight looking, but he's a young fit patient, and he fits into his shell particularly well. And when we look at all 3 together to right up to the 77.4, we say, okay, if our cord surface, we don't want to give any more than 63 Gray, let's look at that and let's essentially see what we have managed to achieve. And therefore we can see that we've actually got really good dose right up to the tumor and to the margins around it. And I think that that's about as good as we're ever going to get. That's true dose escalation. You couldn't manage this with photons. And obviously we have to wait because it's early days yet. This is only a few months out, and we have to see what happens longer term. Fourth case is a 58-year-old who has a chordoma and thoracic spine. Critically, however, he has decompression in a sarcoma unit. And because of COVID, there's a delay. Then he does go on eventually to have en-bloc resection and is referred to us. Thoracic spine scans in the sagittal and also the transverse initially. As you can see, post-stabilization, but he has got a progression of his disease as well. Learning points for us was when we were doing the MR scan and the CT MR fusion with the preoperative scan. Although this was checked multiple times by very experienced people, including radiologists, we found that it was actually out by a couple of vertebrae, and the MR in the treatment position and the CT in the treatment position done in the same day were still not quite able to be in exactly the same position, and they were out by a couple of millimeters, which was obviously critical to us in this case. So in the orange is the pre-operative GTV, or our version of it, reconstructed. And unfortunately in this one, also in orange, is our low-dose CTV, which this time we do take a little bit beyond the muscle, but only in the area where the scar is. Because again, this is a clean operation, if you like, with a sarcoma surgeon. And we're essentially really just covering the surgical bed. Pre-operative GTV again, but the low-dose CTV, which does go out, it is a centimetre above, it is into the covering the area where there have been vertebral screws. It doesn't, however, necessarily cover all of the scar, which is these little blobs in green on the body, because again, this is being done cleanly by a surgeon that knows what they're doing. So GTV again in orange, low-dose CTV this time in a much more appealing magenta, and then the phase 2, because that's only to 50.4, is the red, where we've gone a little bit beyond the gross tumour volume, but I've had to then arch back in along the dura and then come out again at the other side. Again, we have the sagittal view of this, the magenta, the phase 1, and the red, the phase 2. The yellow is a structure which is the center of the spinal cord, and that is what drives the algorithm and the optimization. So again, for the phase 1, 50.4, we've not used all of our dose for the spinal cords. We've only gone deliberately to 95% of the cord, cooled it slightly, because we know we are going to have to donate some of that to the phase 2, which, as you can see there, is covered anteriorly, but there are some of those little horns, if you like, that come around, which we just cannot cover safely and still stick to the spinal cord dose. Overall, it still looks pretty good, and certainly better than one could have achieved with photons in terms of dose escalation. The carbon gives us some security. The cord is within our organs at risk constraints, and posteriorly is the area just covered, not because of tumour per se, but because of the need for to cover the area where the surgeon has been. Interestingly, this patient had said that he had some problems with his scapula, and on the left is his pre-radiotherapy planning CT. And during treatment on one day, the cone beam CT, where there was an immediate stop to treatment, where the scapula looked as if it had entered the lung, but in fact the patient was himself able to self-manipulate his scapula back, thankfully. And this final patient is a patient who, unusually in the mobile spine, didn't have surgery, and this is definitive. It's a chordoma. We think that the radiologist very kindly gave us that element of separation whenever they did the biopsy, confirming the chordoma. And so they didn't have the dura opened by a surgeon, and therefore we felt it was safe, instead of having our phase 1 covering all of the dura and going right round the spinal cord, that it could carve out for the phase 1 with about a centimetre and a half in some directions of margin. And then the phase 2 is the orange stroke blue, as in the GTV equals the CTV. And that's just the sagittal to show again about 2 centimetres above and 2 centimetres or a vertebra below. And the final sum for this patient showed excellent conformality with a really high dose in the area where we want it to be, of 75.6 gray, respecting the cord, also giving a relatively low dose bathe to the muscles, because this patient had to wear a cervical collar all during treatment because of pain. Now that COVID's over, the hope, well, over-ish, the hope is that he will be able to go on to have cervical stabilization, stroke fusion, and not have any increase in wound complications because the dose is relatively low. But you can see that the dose went up to the posterior pharyngeal wall, because that's where the tumor went up to, and therefore just anterior to that with the air, it actually overspilled a little bit into the base of the tongue. So he did have a bit of mucositis, but he didn't need nasogastric tube feeding. However, for other patients, especially patients with head and neck rhabdomyosarcomas, etc., where they get chemo as well, they do have to have gastrostomies, because any weight loss or any change in their outline is really, really critical to us. So we've learned masses from you, and I hope you've learned a little tiny bit from me today. We read every bit of your operative notes. We need a really clear statement of every bit of hardware you've put in, cages, screws, bone graft, whatever. We really, really value when you join us in the MDT. We would love to be able to have more discussions pre-operatively. We'd love to be able to give the tumour 19.8 gray and 11 fractions pre-op, and then complete the 70.2 gray post-operatively. We think that gives a better dose distribution. That's what Boston have done, and therefore that's the best recorded evidence that we have. We're only starting at 19.8 because that's what they did. We might be able to increase that dose with time, but we can only do that in cohorts where we know that it's safe. Obviously, where you put in proton count materials is helpful, and just, you know, making sure that the channels of communication stay open. So I'm very willing to take any questions. You're very, very welcome to email me and to join in where possible at the MDT. Thank you so much for your attention.
Thank you very much to both speakers. I think that concludes this session. We should have some time for the discussion following the lecture of Professor Boriani.